All right, it is noon on the dot, so we're going to go ahead and get started. Hello, everyone, and thank you for joining us today. Today's Cancer Care virtual seminar topic is skin cancer prevention. My name is Annie Gebbe. I'm an outreach coordinator for the Samaritan Cancer Resource Center, and today I will be your host and moderator. This event is brought to you by the Samaritan Cancer Resource Center. We partner with anyone touched by cancer to provide the support they need to live with strength, determination, and hope into the future. Joining us today is Dr. Sterling Farrer from Silver Falls Dermatology. Thank you so much for being here with us today. We look forward to learning how to stay safe in the sun, and thanks so much.
All right, thank you. I'm happy to be here. Talk more about skin cancer prevention and screening. I'm a resident physician at Silver Falls Dermatology, mostly work up in Salem. So this is an important topic. Skin cancer is caused by many different things we know, including lifestyle and genetics, but the most important thing, and something that we can control, is our exposure to the sun. From the sun, we get ultraviolet radiation, which has been shown to cause skin cancer. So sunlight emits a wide range of radiation energy, including visible light and ultraviolet light. And under ultraviolet light, there's two types of ultraviolet light, UVB and UVA. And these types of ultraviolet light are the most dangerous to the skin, and what we've seen that has actually shown to develop skin cancer. So UVB, if you look at our wavelength spectrum down here, so light that we can see falls within the 400 to 700 nanometer wavelength. And the wavelength just shorter to visible light is our ultraviolet light. And this is emitted by the sun. UVB has a wavelength of 290 to 320, and it is absorbed in the epidermis, which is the top part of our skin. And then UVA has a wavelength of 320 to 400 nanometers, which reaches the deeper part of our skin, called the dermis. And then visible light is between 400 and 800 nanometers. We also know that the higher you get in elevation, the more UV exposure we get. So UV exposure increases by 4% for every 1,000 foot of elevation above sea level. And you may have seen or heard of this when someone goes on like a skiing trip to Colorado, not expecting to get sunburnt in the middle of the winter, but because of their increased elevation and increased UV exposure, they come back with a pretty bad sunburn. So talking about the short and then long-term risks of UV radiation, short-term risk is sunburn, which I think most of us have experienced. So the skin becomes red and tender in the hours after sun exposure. And this comes from, so keratinocytes are the cells that make up our skin. And those are damaged predominantly from the UVB light. So the cell cycle is followed by repair of the injured DNA. So also apoptosis, which is cell death, occurs because of a sunburn. And one way to remember this UVB, B is for burning. So the UVB wavelength is what causes sunburns. And then we also get some immunosuppression, some skin thickening, and inflammatory cytokine stimulation from a sunburn. So you may have noticed that in very severe sunburns, people even develop a fever, and that's because of this inflammatory cytokine stimulation. So the long-term risk, what we're more talking about today, is photocarcinogenesis, which is skin cancer. This is a fancy term for skin cancer. So sun exposure and sunburns increase the risk of several types of skin cancer. So we're going to talk about each of these briefly today, but just as a brief overview. So basal cell carcinoma, this is the most common type of skin cancer, is rarely seen in children. And then squamous cell carcinoma, also rare in children, and then melanoma. Melanoma is the most deadly form of skin cancer. About 1 to 3% of cases actually occur in the pediatric population. And that's because in melanoma, there's actually more of a genetic risk factor than there are in these other non-melanoma cancer types. So sunburns increase the lifetime risk of melanoma. So a study in 2008 showed that any sunburn before the age of 13 made almost 2 times more risk for melanoma. And then any sunburn between 13 and 19 years old, a 1.6 times chance of developing melanoma. And then any sunburn after 19 years of age, 1.4. So you can see the earlier age where someone develops the sunburn, the greater the risk. And we have a lot of patients that come into our dermatology clinic, and we end up doing a biopsy and diagnosing skin cancer, and they say, well, I've been using sunscreen and I've stayed out of the sun for the last 40 years of my life. I don't know why I developed this skin cancer. And that's because most of the sun damage we do, some people even say up to 80% of the skin damage we do come before we turn 19 years of age. So that's why it's so important to talk about this with our pediatric population too, because at a very young age is when we start preventing skin cancer later in life. Another big factor that's definitely led to the increase in melanoma are tanning beds. And there are some misconceptions about tanning beds that I wanted to talk about. So in this case, a 17-year-old Caucasian girl presents for a health maintenance visit with her mother. You ask about the use of tanning beds. Your patient admits to occasional tanning. She explains that she has been tanning to improve her health, since her vitamin D was recently discovered to be low. She also wants to decrease her risk of sunburn on her upcoming family vacation to Florida. So let's talk about some of these misconceptions. You may have heard of people going to a tanning bed to get a tan before going on a vacation, saying it's going to prevent them from getting a sunburn. So a suntan provides protection that is equivalent to an SPF 4 or 30. This is not sufficient to prevent sunburn. If you're familiar with most sunscreens, most are SPF 30 or above, which is generally the dermatologist recommendation is that we should at least have SPF 30. So these people that are going to tanning beds to get a tan before going on a trip, not only are they causing damage to their skin that can later lead to skin cancer, but they're only getting a protection of about SPF 4, which is not sufficient to prevent sunburn. Tanning beds emit mostly UVA radiation, and vitamin D synthesis occurs in the UVB range, around the 300 nanometer length. So tanning beds also are not an effective way for vitamin D synthesis. It's not a good, and by far not the best way to increase vitamin D in our bodies. Increased dietary intake of vitamin D is the safest and definitely the most effective way to increase vitamin D levels. They've even actually done studies on surfers in Hawaii that have been shown to have low vitamin D levels. So it's not just our sun, it's genetics, and there's dietary habits. There's lots that go into our actual vitamin D levels. And the best way to treat low vitamin D is through taking dietary intake. It's not from going out and getting more sun exposure. And then, as we mentioned, using sunscreen does not eliminate risks of tanning beds. And then another study, 2007, showed first exposure to indoor tanning beds before age 35 increased the risk of developing melanoma by 75%. And ever use, so anytime ever in someone's life that they used indoor tanning equipment, increased their risk of developing melanoma by 15%. So another important topic, so we talked about how important it is starting at a young age to start protecting yourself from the sun and UV radiation. So a 4-month-old girl comes in for her routine visit. The patient's father notes that the family is going to Disney World for vacation. Yes, what sunscreen do you recommend I use on the baby? So important information here. So the American Academy of Pediatrics recommends sunscreen use in young infants only if adequate clothing and shade are not available. Infants are at risk of systemic absorption of chemical sunscreens with widespread use. So physical sunscreens are preferred. And then careful education of parents regarding these concerns and emphasis on other forms of protection should allow families to safely bring infants to sunny environments. So to break this down, the most important thing is to actually use clothing and proper use of shade to protect the infant. If that's not available, then using physical sunscreens such as zinc oxide-based sunscreens are going to be much better to use than in kids. Young infants' skin is much more susceptible to developing allergies and irritation, where using a physical sunscreen like a zinc oxide, they're not going to develop that irritation from that. So just talking about the different types of sunscreen. There's physical blockers, and then there's chemical sunscreens. So first going over physical blockers. So those are the ones that are, and it will say right on the bottle, if it has zinc oxide, titanium dioxide, or iron oxide. Those ingredients are physical blocking agents from the sun. They block and scatter UV and visible light. They're less irritating to sensitive skin, and they're immediately effective. Chemical sunscreens, which are a bit more popular, they absorb light and re-emit energy as insignificant quantities of heat. The active ingredient in these include benzophenone, avobenzone, and oxybenzone, and then others, mostly a lot of them end with this word benzone, which is a type of chemical ingredient that, like as we said, re-emits the energy to prevent sunburns. So the advantages of this are they're not as messy, they're easier to apply, and they're less apparent than like the white sheet that you usually see with the physical blockers. So bottom line is chemical sunscreens are safe. I recommend SPF 30 or above, and especially if you don't have sensitive skin that you've noticed reacts to the chemical agents and chemical sunscreens, they're totally fine to use. As you see, there are some advantages. On young children, or if you have history of eczema, other irritated, sensitive skin, then definitely recommend one of these zinc oxide, titanium dioxide, or iron oxide based physical blocking sunscreens. So SPF, what is SPF? So we see that as a measure on sunscreens. It's calculated using this equation. The amount of time it takes to produce erythema, which is redness, on sun-protected skin, divided by the time it takes to produce the same redness or erythema without sunscreen. So theoretically, someone who normally burns after 10 minutes after they put on SPF can stay outside 2.5 hours or 15 times longer with wearing SPF 15. So how to choose and apply sunscreen. Sunscreens are best for protection against UVB and UVA rays. SPF only measures protection against sunburn from UVB. Excuse me. Doesn't actually measure effects from UVA. As we remember from our previous slides, UVB is what is causing the burning. But UVA can also cause damage, leading to aging effects and possibly contribute to skin cancers as well. So it's best to find a broad spectrum sunscreen. Broad spectrum refers to they block both UVB and UVA light. SPF 30 or greater is recommended. SPF 30 blocks 97% of the sun's rays. When you go up to SPF 60, SPF 100, you're getting a little bit more, maybe 98 or 99% of the rays, but not much more. So we say at least something SPF 30, 97% is a very good amount to block. And then especially if you're outside sweating and going in the water, then sunscreens need to be reapplied every few hours. Sunscreens must be applied in an adequate amount to obtain the expected protection. Excuse me. The average adult should use 1 ounce, a shot glass size, per full body application. Other ways to protect from the sun. Avoid sun exposure during peak hours. Sun's rays are strongest between 10 a.m. and 4 p.m. Seek shade when your shadow is shorter than you are. And then use photoprotective clothing and hats. So we talked about SPF for a sunscreen measure. So there's photoprotective clothing where they use this UPF, ultraviolet protective factor. And you'll see that with a lot of clothing, they'll actually list the UPF factor on the clothing. So anything above 15 is good. If you get up between 40 and 50, that's excellent. But when looking for clothes that are sun protective, I would look for this factor, that it's at least above a UPF of 15. All right, so now we're going to talk a little bit about the common types of skin cancer we see. And we talked about melanoma. Melanoma, out of all the skin cancers, is the most scary. It definitely has the highest risk of death of all the skin cancers. So it's one to be aware of how it looks and how to detect it. In 2019, it is estimated that there will be 96,480 new cases of melanoma and 7,230 deaths from melanoma in the US. The lifetime risk of melanoma has increased. Back in the early 1900s, about 1 in 1,500 people developed melanoma. Now in 2014, at least amongst the white population, 1 in 38. So 2.6% of people develop melanoma. And it's going to be a little bit lower for other darker colored patients, 1 in 167 for Hispanics and 1 in 1,000 for African Americans. Melanomas can affect all ages. It is actually the second most common cancer among young women between the ages of 15 and 29. So here's a look at some different forms of melanoma. And we'll talk about kind of a general rule that we talk about as dermatologists to look for and screen for moles that may look a little odd. But here are some definite cases, and things you look for are this black pigment. That's something that has in common. A black pigment in a non-symmetrical skin lesion. So if this was a skin lesion prior, and then all of a sudden this dark globule appeared to the outside, that would be concerning for melanoma. And then just anything that has this dark of a color in general. You can even see there's some brown here, and then around the brown is a pretty dark black nodule. That's concerning. And then you want to especially be on have a careful watch over sun-exposed areas. So you can see here on the ear, if this patient, if you were to develop asymmetric dark colored lesion, like on a very sun-exposed spot, like the back of the ear, another reason to look into it. You can also develop a skin lesion, melanoma, where you don't have as much sun exposure. Because as we mentioned, there's definitely a genetic component, and sometimes even if you haven't had a lot of sun exposure in that area, you can still develop melanoma. For example, here's melanoma on the back of a heel, melanoma on a toenail, and then even this spot here, you can see it's mostly pink and scaly, but it developed this black spot. So anything where you're developing new black spots, it's good to get checked out. So we'll talk a little bit more about this. So this is a sheet that we like to give for patients that have either a lot of moles or have a family history of melanoma. It's called the ABCDEs of melanoma. So A stands for asymmetry. So when half of the lesion is unlike the other half. B is for border. So when it has an irregular, kind of scalloped or poorly defined border. Color is when something starts to change color and it varies in color. You have part of it that's tan, you have part of the lesion that's brown, and then part of the lesion that's black. And then diameter. A general rule we use is if something's greater than the size of a pencil eraser, which is about 6 millimeters. And then the last one, and probably the most important, is evolving. A mole or skin lesion that over a few months period of time has gone from something looking like this to something a lot bigger and asymmetric looking. So And you may have a mole that has one of these, and it may still end up being okay, but especially looking in when a lot of like when it starts to have an irregular border, the color's changing, the diameter is bigger than the size of an eraser, those are ones that we definitely worry about and take a biopsy of. Okay, moving on from melanoma, squamous cell carcinoma. Squamous cell carcinoma most commonly occurs among people with white or fair skin, commonly located on the head, neck, forearms, and dorsal hands, so pretty much sun-exposed areas. Just like with melanoma, there's an increased risk of developing squamous cell carcinoma with tanning bed use. For African Americans, incidence of squamous cell carcinoma of sun-protected and sun-exposed skin presents equally. So in Black, Asian, and Hispanic patients, squamous cell carcinoma of the skin has a disproportionately elevated morbidity and mortality. Increased associated mortality compared to basal cell carcinoma. So to put them in a spectrum, melanoma is definitely something that we're most concerned about, has the highest risk of metastasis. Squamous cell carcinoma would kind of be the next down the list. Definitely not as high of a risk, but these do metastasize, and there's something that we do have to look out for, spreading to lymph nodes and other parts of the body. So what do squamous cell carcinomas look like? They have various morphologies, but just to kind of point out a couple, they can either be a papule, which is a raised bump, a plaque, which is kind of a raised bump over the size of a centimeter, or a nodule. They can be pink, red, or skin colored. They're usually scaly. And exophytic meaning they're growing outward. You can see this kind of keratotic horn right here that's been growing outward. And they feel pretty thick when you touch it. They're usually not soft and boggy. They usually feel pretty firm. And then they're generally very friable, meaning that they bleed with minimal trauma and then they crust over. Usually asymptomatic, but they can be itchy or tender. So definitely any lesion you have that's raised, growing outward, scaly, something to get checked out for sure. So not as noticeable, but what are these? These are, as you can see, rough, scaly, thin, white to red, pink, tiny plaques scattered on the forehead and right temple area that are very common. So these are not yet squamous cell carcinomas. These are precancerous lesions called actinic keratosis. Very common. And so actinic keratoses, they're considered to be a part of a disease spectrum. So we get photo-damaged skin from the sun, and then because of that photo-damaged skin, we develop these white little scaly bumps. And those are called the actinic keratoses. We say about 5 to 10% of these over the span of 10 years will develop into squamous cell carcinoma. And first it becomes squamous cell carcinoma in situ, meaning it's just in the top layer of the skin. And then after that, it will start to invade down into the deeper part of the skin. So even though, these are an urgent thing to watch out for, they're good to get treated because they can develop into squamous cell carcinoma down the road. All right, moving on to basal cell carcinoma. Basal cell carcinoma, most common skin cancer worldwide. It arises from the basal layer of the epidermis, which is so this purple part here is the top layer of your skin. And the very bottom of this junction, is called the basal layer. So after sun damage, this basal layer can get out of control and start growing down deeper into the deep skin. And that's what creates a basal cell carcinoma. So UV radiation induces the DNA damage, and then it creates a loss of function in this gene called patch1. So what do basal cell carcinomas look like? These can look a little different than squamous cell carcinomas. Some of them look similar, but these have more of a shiny look to them. They're usually pearly and can have overlying thin blood vessels over the top. They can even be pigmented at times. You can get pigmented basal cell carcinomas. And then this here is a superficial spreading basal cell carcinoma. And so these can be pretty hard to tell apart from different benign inflamed lesions on our skin. So it's always good to come in and get these checked out when you have a growing red scaly lesion. So just to talk a little bit more about basal cells, they're on that spectrum of melanoma and squamous cell. They're much less likely to metastasize, but even with the low risk of metastasis, they will continue to grow in the epidermis, or in the upper part of the skin. And the larger they get, the harder the surgery is to remove it. So it is good to catch these early before they grow in size, and especially like basal cells like this on the nose. These can be very challenging to treat surgically. So talking briefly about the treatment for these. So you may have heard of this, Mohs micrographic surgery. So Mohs is the name of, Frederick Mohs is the name of the physician who created this technique. But what it does is it offers a complete histologic analysis of 100% of the tumor margins while permitting maximal conservation of tissue compared with standard surgical excision. So before Mohs, what we would usually do is we would cut out the skin cancer, what we could see of it, taking about 4 or 5 millimeter margins of healthy tissue around it. And when you're working on places like the ear or the nose, taking that extra bit of healthy tissue made repairing the defect afterwards very challenging. So now with Mohs, you don't take any of the healthy tissue. You're just taking the skin that is involved with the skin cancer. And then because we're able to look at 100% of the margin to make sure it's clear, recurrence rates are very low. And they're even lower compared to other modalities, including standard excision, keratogen desiccation, radiation, and cryotherapy. So depending on where your skin cancer is, it may meet the criteria for Mohs surgery. Definitely on the nose, ears, eyes, lips, scalp, hands, or if the skin cancer you have is one of the aggressive types, infiltrative, sclerosing, morpheoform, or micronodular, that will meet the criteria. Or if it's a large tumor, usually we define that as being over 2 centimeters with indistinct clinical borders, or a tumor that you had recently or previously and then was treated and then came back. For any of these criteria, you would be sent to a Mohs surgeon to do it. All right, that is all the material I had. Do you guys have questions?
Thank you so much for that. That was so interesting. And yeah. I particularly liked the details about the sunscreens because, you know, we're all told to use it, but I couldn't have defined SPF before today. So thank you so much.
Yeah.
I'm going to give everyone a few more seconds to write in questions to the question menu while I go over a couple details about the Cancer Resource Center and what we have going on. If you'd like additional information or resources about cancer, please feel free to reach out to us by phone, email, walking in when you're in the office, checking out our Facebook or Instagram. And you can also email us if you'd like at cancerresourcecenter@samhealth.org. Couple upcoming events to round out July. We have Decoding Your Mammogram happening next week, as well as Cancer and Sexual Health, part 2 of our series, and Grief and Loss at the end of the month. We are also planning a partnership with Silver Falls to do a skin cancer screening at the end of the month on Friday, July 29th. Sign up for that should be available next week, so we'll be sure to send out instructions on how to sign up for that. If you are interested, we would love to have you come in for a free spot check or full body screen. So keep an eye out in your email for those details. All right, we do have a few questions for you. Let's start off. At what age can children use chemical sunscreens?
So great question. At about age 2, I would see if the child would be able to tolerate it, because like I mentioned, a lot of times they're a lot easier to apply than the like zinc or mineral-based sunscreens. But definitely for a child under 2, I would stick to the mineral-based sunscreens just because their skin can really flare up with some of the chemical-based ones.
Thank you. Next up we have, is there a greater risk for people who have birthmarks to have a greater risk of skin cancer?
Good question. So the risk for melanoma, with birthmarks, there's no increased risk for melanoma. The ones to look out for, any first-degree relative with melanoma, there's definitely increased risk, and it's a good idea to start skin checks earlier in life if you have a first-degree relative. The other risk factor that's related, so if someone has over 50 moles on their body, even if all the moles are benign looking, just the fact that they have greater than 50 moles is another risk factor for melanoma. But as far as birthmarks, there is one type of birthmark, it's called a giant congenital melanocytic nevus. It has a very long name. And if that measures over 10 centimeters in size, then that is a risk for melanoma. But as far as your standard birthmarks, no increase in risk.
Thank you. Someone asked if there was a way to re-watch today's presentation, and there is. We are recording this, and it will be available on the Samaritan YouTube page in about a week or so. I'd be happy to email that link out once it's available to you. Next up. We have a participant who had a squamous cell carcinoma on their nose and grew up playing out in the sun without sunscreen. They were wondering how often they should get periodic skin checkups.
So how our office does it, after your Mohs procedure, we'd have you come back in 3 months for another skin check. And then after that, if everything looked good, we would do 6 months. And then it kind of depends if we're continuing to develop squamous cell carcinomas, or they have a bunch of those precancerous lesions called actinic keratosis. We may see you more often, every 6 months. But the general rule for the general population is a yearly skin check.
Are spray sunscreens just as effective as lotion varieties?
Yes. And as you may notice, I think there's very few mineral-based spray sunscreens. So if you prefer the mineral-based, if you have sensitive skin, I'm not sure there's too many of the spray ones. But as far as the chemical-based sunscreens, it's really whatever modality you prefer. If the spray works better, then that works just as well.
Are loose powder zinc sunscreens as effective as traditional sunscreens, such as lotion or spray?
Yes, definitely.
And so many questions. I love it. Thanks for the engagement, everybody. Let's see. Do I have to go to my family doctor first to get spots looked at? I'm guessing that's probably specific to your practice and what sort of referral.
Yeah, and I think that's also specific to your insurance. I think every insurance is different, but I think a number of insurances do require you first to go to a primary care physician, and then they can refer you to a dermatologist from there.
That's great advice. Thank you. And I do know that if you have an insurance plan, you are able to call them and ask what sort of barriers there may be to seeing a dermatologist, or what sort of route is best for coverage. Lots of people saying thank you. And someone said, what about tattoos? I'm guessing, I'm going to just interpret here. Do tattoos have any sort of weigh in on skin cancer risk that you know of?
Yeah, the only challenge it presents, if a patient is heavily tattooed, a lot of times a lot of skin cancers can hide in the dark pigment of a tattoo. So I would say, you just have to be extra careful if you're doing self-screening exams, to really feel for any scaly patches, because a lot of times the redness that we appreciate from different skin cancers aren't really noticed in a dark pigmented tattoo. So you just have to kind of feel for the scaliness rather than just look for color changes.
Can you explain what happens during an initial appointment, what to expect, and what the whole exam entails?
Yeah. So generally, we recommend doing a full skin examination. So in our clinic, what we do, you come in, if you agree to do a full skin check. If you prefer not to do a full skin exam, we can just do spot checks. Like if you have a spot here or there that you have questions about, that's also fine. But we generally recommend, especially if you haven't seen a dermatologist before, to do a full skin examination. You'll be given a gown, you'll change into a gown, and then the physician comes in with the medical assistant, and we answer any questions you have first. And then we usually just do head to toe, full body skin screen for any skin cancers.
Great. And last up, will the slides be available? Dr. Fair, would you be willing to
Yeah, I can
share your slides with us?
Yeah, I can send those over. Yep.
Great. If you could email those to me, I can make them available to all our participants.
Okay.
Thank you. And that wraps up our questions. Thank you, everybody, for engaging. And those were great questions.
Yeah, great questions. Yeah, thank you.
And that rounds out the presentation. We do have a survey that will go out at the end. If everyone could please fill that out for us, let us know what you liked, what you didn't like, if there was anything you'd like us to improve on, or if there's topics you'd like to hear about in the future. We love to hear from you. Everyone's writing in saying thank you, and they appreciated the webinar and all the great info. Dr. Fair, thank you so much for being here with us today. We really appreciate it. And you know, this information is so valuable, especially during these summer months when all we want to do is go outside.
Yeah. Well, thank you very much. You guys had great questions, and it was a pleasure.
Thank you so much. I hope everyone have a wonderful weekend. And